I am a board-certified dermatologist in New York City, and I spent the early part of my career, about 6 years, with a specialized skin cancer surgeon, a Mohs surgeon. And I spent 6 years doing the treatments, the surgeries, and the fix-up after the surgeries for skin cancers. So this is a real important topic. It's dear to my heart. And so today I would like to talk to you about skin cancer and the prevention of skin cancer. The first thing I like to say is that skin cancer is on the rise. It is the absolutely most common skin cancer all over the world and includes the US. And it's also the most common cancer in young people ages 25 to 29. Malignant melanoma, which is the most dangerous kind of skin cancer, is also on the rise. So this is an important topic, and it's important to look out for the skin cancers in yourselves and in your close ones. An ounce of prevention in terms of skin cancer is really worth a ton of cure. Early detection of a melanoma gives a 99% 5-year survival rate. When it's discovered late and it's spread, it only has a 25% 5-year survival rate. So that's a very big difference. So we really want to find these early and be able to treat them. We also know that 5 or more sunburns double the risk of melanoma. So it's important to talk about that, and it's important to look out for the causes and the treatment. We know now that skin cancers come mostly because of UV radiation, or as we call it, sun exposure. So let's talk a little bit about UV radiation. What is UV radiation? As we know, the sun emits a whole gamut of rays. And on the left side, you can see UVA and UVB and also UVC. On the right of that is the visible spectrum, and the infrared on the left of that I meant. And the right, the infrared spectrum, is the heaters that we use in the winter and so on. UVA and UVB are the rays that can enter and damage the skin, and are the most important reason for the appearance of skin cancers. There are 2 types of sunburns that we differentiate. The UVB-related sunburns appear immediately, immediate redness, immediate erythema, as we call it. UVA causes the kind of sunburn that starts peaking about 24 to 48 hours after sun exposure. It's deeper reaching, but it also causes deeper damage. So what happens when we have sun exposure? First of all, we should know that there are a lot of different bad cells or distorted cells that circulate in the body every day. Our immune system is the police of these cells, and it looks out for these cells 24 hours a day, and it eliminates them. And usually the immune system is able to eliminate all those cells on an everyday basis. But sometimes the immune system gets overwhelmed. For example, as somebody has a lot of severe sunburns. And so some of the bad cells don't get policed and they don't get eliminated. And they're able to give rise to new cell lines that have damaged DNA. And from that, we start getting malignant lesions, malignant skin tumors. The types of skin cancers we talk about are the non-melanoma skin cancers and the melanomas. Melanoma is a class on its own. It's very important to talk about separately. This is what we see in terms of skin cancers. On the top, there are basal cell and squamous cell cancers, which are non-melanoma skin cancers. And on the lower left, you can see a melanoma. It's usually brown lesions, and they're very ominous looking. I'm not going to talk today about Merkel cell tumors because they're very rare. They're kind of non-melanoma skin cancer, but not really relevant to the topic today. So in the non-melanoma skin cancers, basal cell carcinoma is the most important, and it's also the most common. It appears on sun-exposed areas in most people, and you can see it can be on the face, it can also be on other body parts. And when you look at a basal cell carcinoma, very typically they early border. They have kind of a rolled outside, and they have little capillaries that cross them inside. This is, of course, not all of them, but most of them. They sometimes start bleeding and scabbing. They start growing over time, and they grow locally, and they get bigger and bigger. So the earlier you find them and the earlier you treat them, the smaller the scar and the aftermath of the basal cell. The most important lesions are the ones that we find in the midline of the face, close to the eyes or the lips or the mouth, because these are the ones that can cause trouble and are more difficult to get out without causing a lot of damage. The second type of non-melanoma skin cancer is squamous cell carcinoma, or so-called SCCs. These can be either superficial or deep. The superficial lesions can be treated easily, but the deep lesions, unlike the basal cells, can potentially penetrate deep and reach the blood vessels under the skin, and from there they can potentially spread. So it is very important for this reason to find these, diagnose these, and treat these as early as feasible. The squamous cells usually, or at least often, arise from precancerous lesions, which are called actinic keratosis, and I will show you some of those. So if you look at a squamous cell carcinoma, you can see it's very different from the basal cells. It's kind of scaly, it's red, it looks kind of dry, irritated, and if they grow, they just keep looking the same more and more, and then at some point they start bleeding, and they become very ugly looking, very ominous looking. This is another kind of a squamous cell carcinoma. It's a little earlier. You can see it's not as much scale. And these are sometimes so innocent looking that people don't suspect that they could be something that should be checked and taken care of. And that's why it's really important to show your skin once a year at least to a board-certified dermatologist. So like I said, very often these squamous cells come from an actinic keratosis. An actinic keratosis is a sun-induced lesion. Usually these are found on the face. For men who have no hair, bolder men, you can see a lot of them on the scalp. And when you touch them, they feel like sandpaper. Often you can't even really see them, but you can just feel them with your fingers. And these, if they're left alone, a certain percentage of them turns into squamous cells. We don't know which of these lesions is or is not going to turn, and therefore it's very important to treat them all. So this is an example of more of these precancerous actinic keratosis. And you can see that they are kind of, scaly and dry looking. These do not yet have that redness that the squamous cell carcinoma has, where the immune system is already trying to deal with them, even though it's not really successful. We can see these precancerous spots on the face, but also on the hands, the arms, the chest, any kind of sun-exposed area. They can appear anywhere. So actinic keratosis can be precursors to squamous cell carcinomas, and we have the other category of basal cells. These are the non-melanoma skin cancers. Now, I would like to talk about malignant melanoma. Usually melanomas are brown, although there are exceptions, but usually melanomas are brown. They can arise from an existing mole, or they can arise because they are inherited. They can be the result of blistering sunburns, or they can just spontaneously appear. As I said before, 5 blistering sunburns double the risk of developing a malignant melanoma. And so it's important not to have those sunburns, but anybody who had those sunburns in their youth can just go to a dermatologist to make sure that their moles are not cancerous, because early detection and treatment, especially for melanomas, are crucial. So let's talk a little bit about what we call the ABCDs of a melanoma. A stands for asymmetry. On the right, you see a normal mole, and you can see that if you cut it on an axis in the center, no matter in which direction, you will get a pretty symmetrical half on each side. On the left, you see a melanoma. If you cut this around either axis that you choose, you're not going to get symmetrical help. This is not a symmetrical lesion. So asymmetry is one of the hallmarks of malignant melanomas. B stands for border. On the right, you see a normal mole. It is sharply defined. The border is very well circumscribed. There's nothing coming outside of the border, no color, no growth, as opposed to the left side, which is a melanoma. And you can see that the border is kind of jagged, and sometimes you can have color spilling out. It definitely does not look like a regular, sharply defined skin growth. So we have asymmetry and borders. But let's talk about the color. A normal mole is going to be one color. Sometimes it's brown, sometimes it's dark, but it's still one shade of brown, one shade of orange or red. So the melanoma, which you see on the other side, is different. It has different shades of brown. Sometimes it can be black. It can have areas of red where there are blood vessels that arise. And sometimes we even see white color in them, where the body, the immune system, is trying to eliminate them. And so these variegated colors mean that we are dealing with a malignant melanoma. The last letter is D. D stands for diameter. And what that means is that the normal moles are usually the size of a pencil eraser or smaller, or about 5-6 millimeter size. When you're dealing with a malignant growth, usually they are bigger. They are definitely over 6 millimeters. However, none of these characteristics are 200% accurate. So some melanomas can appear to be like very benign, very even colored, and we really have to know which lesions to biopsy and which lesions to skip. So please, don't try to diagnose yourself and, judge your moles. Go and say, yeah, let somebody look at them. But if you know the ABCDs, you know what are those signs that you got to look out for and get alerted to the fact that somebody should check it sooner rather than later. These are atypical or so-called dysplastic moles. Often melanomas do arise in these atypical moles. And if you look at these pictures, you can see that some of these atypical moles are just as ominous looking as melanomas. We do not know which one of these moles will or will not cross the line and become a melanoma. Some of them never will, but some of them will. And since we cannot know for sure, we like to treat these early and get rid of them, because a lesion you don't have is not going to turn into cancer. This is an example of a malignant melanoma on the face. And as you see, it's fairly close to the eyes, it's fairly close to the nose. These lesions are very difficult to deal with, but they can be dealt with. The earlier you deal with them, the smaller the damage, the smaller the scar. And of course, the survival, the 5-year survival is much better. This is a less ominous looking, but still significantly irregular malignant melanoma. It's the face of a younger person. Younger people can get melanomas, and that's very important to remember. So how do we diagnose these melanomas? First of all, we encourage patients. I encourage my patients, and I encourage all of you to examine yourself. Look at your moles. If something changes, if something gets suddenly bigger, it starts changing color, if it starts itching or bleeding or hurting, anything that's unusual, the easiest thing to do is make an appointment with a board-certified dermatologist, have it checked. We are going to know if it's something that needs to be biopsied, or we are going to reassure you and say, don't worry about it. Any person should really have 1 or 2 times a year a total body exam with a dermatologist. We are board certified. We spend many years in training to be able to tell these things apart. So this is in your benefit, and you should take advantage of doing so. Any lesion that we find that is suspicious, we are going to biopsy. I just wanted to show you that the actinic keratosis, which you talked about, which are precancerous lesions for squamous cell carcinoma, can often be treated very easily with some liquid nitrogen. We freeze them. It's liquid nitrogen at very low temperature. Repeated freezings will get rid of these actinic keratosis, And again, if you don't have something on your skin, it cannot cause trouble later. When we have an outright skin cancer, we often refer people for Mohs surgery. Mohs surgery is a specialized skin cancer surgery. And unlike in regular cases where we take a biopsy and we send it to the pathology lab, and a week or 2 weeks later we get the result, a Mohs surgeon has a lab on the premises, and they can take a piece of skin, freeze it, create so-called frozen sections, and look at them under the microscope right then and there. So they take a piece of skin, they create the frozen section, and they immediately examine it. If there is some more skin cancer left, they can just pick that little spot where they find it, go back, take it out, and examine it again under the microscope. What the outcome of this is that you have the greatest accuracy. You remove all of the skin cancer, but you can create the smallest scar possible. So it's tissue sparing. This is very important because some lesions, for example, on the face, can cause really ugly scars if not treated with the least amount of damage possible. So we like tissue sparing, accurate treatments, and Mohs surgery is the way to do that. Malignant melanomas are a different story. First of all, we want to remove the lesions that are precursor lesions. So we want to treat the dysplastic atypical Mohs. We want to excise them because if we don't have them, they're not going to progress. Early melanomas can be just excised with very relatively small borders, and the cure rates are absolutely excellent. These melanomas are usually done and gone. However, when they allow to go deeper, now we are forced to do bigger excisions, leave bigger margins around so that we don't miss any cells that skip from the borders. And very often now we have to do follow-up tests. We have to do chest x-rays. We have to do blood tests. Sometimes we need CAT scans and so on. If we have a truly deep and widespread melanoma, this patient will need oncologic treatment, which is now a whole lot more successful than in past years, but still, it's something that's complicated. The 5-year survival rates are not nearly as good as for early lesions. The newest method really of treatment is immunotherapy, and it's very successful and interesting. And one of the best institutions for this, Sloan Kettering Memorial, is right here in New York City, and so we can refer patients there. Just remember that early detection is really the key because the 5-year survival rates are dramatically higher than for later lesions. So who is at risk for skin cancer? I'm going to give it away, and if you look on the bottom of the slide, you will see everyone is at risk. First of all, people who have fair skin and light-colored eyes are obviously at risk. Their skin burns easily. They get a lot of sun damage. People who have a history of severe sunburns, we said, are at risk for malignant melanoma. People who have many years, extensive and extensive sun exposure for many years, are at risk for both. But even people with dark skin types can develop both skin cancers and especially melanomas. So nobody is really safe. People who have a family history of skin cancer, a first-degree relative, have statistically higher chances of developing one. So it's very important that everybody examines themselves, consider their own family history, consider their own skin type, the light-colored skin and eyes, or the first-degree relatives, or their own history of having the skin cancer, because once you have one, statistically, you're more prone to getting a second one. So in other words, everybody is at risk. Sun damage is cumulative. Sun damage starts when your mother starts strolling you around in a little stroller when you're a few months old, and it keeps accumulating until it reaches a certain trigger point at which the damage starts becoming apparent, both in terms of photoaging and in terms of skin cancers appearing. And so the sin, which is the sun exposure, is many, many years removed from the punishment, which is the skin cancers and the other manifestations. And so my patients sometimes say, oh, this dermatologist, they say that it's so dangerous, but look, last year I had a sunburn, nothing happened. Well, if I meet this person 30 years later, it might be a whole different story. Sun protection is the most important preventive measure. I like to encourage all of you to avoid the hottest hours outside between 10 a.m. and 3 p.m. Even if you have sunscreen on, try to be in the shade, try to walk in the shade. Use a hat, use a visor, use an umbrella. I walk around with a little umbrella when I go to sunny places and I have my own shade. It feels good. It's not so hot and unprotected. There are companies such as Holy Bar that make clothes that are UV protected. They have SPF in them. And of course, application of sunscreen. So let's talk a little bit about sunscreens. There are two kinds of sunscreens, are the so-called chemical sunscreens and the physical or mineral sunscreens. Chemical sunscreens work by absorbing the rays of the sun, trying to neutralize them. However, often these cause skin irritation and rashes. The most important and the most recognized ingredients of these chemical sunscreens are oxybenzone and avobenzone. So when you see these, you know that you're dealing with a chemical sunscreen. They can be used, but they often cause problems to patients or to people. The FDA now considers PABA, which used to be a very common ingredient, and toluene salicylate unsafe. So those sunscreens should not be sold, but if you see them, please do not use them. Now, the physical or so-called mineral sunscreens work differently. They don't absorb the sun rays. They try to deflect them. These are the sunscreens that when you apply them, they leave a little sheen on top of the skin. Sometimes it's whitish, it can be beige color. These sunscreens contain zinc oxide and or titanium oxide, sometimes both, sometimes one. And these are much more, they're much safer, they don't cause rashes, and they work really, really, really well. When it comes to SPF, more is better. We like broad spectrum sunscreens, meaning that they cover both UVA and UVB radiation, and we like high SPF. So what we consider high SPF differs, but I would say that 30 is the absolute minimum for the face, and I personally prefer 50. Sunscreen needs to be reapplied, and needs to be reapplied definitely after each time you go swimming. The SPF, by the way, which stands for sun protection factor, it doesn't mean that if an SPF is 100, it's going to be 100% protective against sun damage. What it means is that it takes 100 times more time for the skin to get damaged. Now, this is not exactly like if you would burn in 5 minutes, it's going to take you 500 minutes to burn, but it's going to extend the time before you start burning. So high SPF is better than a low SPF, but it's not 100% protection. The other thing I like to mention here is that some people believe that there's not a big difference between an SPF 50 and an SPF 100. And that is not exactly true either. It is true that an SPF 15 and an SPF of 30, there's a bigger difference than between SPF 30 and SPF 60, let's say. But it doesn't mean that the difference between an SPF of 15 to 60 is not huge. So I encourage you to go for the higher numbers, as high as you can. And especially if you're going to be outside and you're going to be in the sun, it's really very protective. And I just wanted to show you here one of my favorites. It's Antelius by La Roche-Posay. It's a really great mineral sunscreen. It's an SPF 50, which I consider a good minimum, especially for the face. And this is the kind of sunscreen that you're looking for. It has titanium oxide and zinc oxide, both of them. It's a mineral sunscreen. No problems, no rashes, no allergic reactions. Very useful. The benefits of sunscreen are Not only that they protect from sunburns and prevent skin cancer, but they also protect against photoaging. And I don't know anybody who would like to have wrinkles, discoloration, or sagging. So sunscreens really are the best anti-aging substance in addition to being protective for skin cancers. So in summary, please practice good sun protection. Use a high SPF broad spectrum sunscreen. Perform some self exams at home regularly, maybe once a month. Maybe use your significant other to look, that's why we say for better or worse. Let them look on your back, let them look at places you can see. Anything that's suspicious or changing or is kind of weird by those ABCD standards should be checked by a board certified dermatologist. And I say board certified dermatologist because we really do specialize and we train in both the detection and the treatment of these skin cancers. Even general practitioners, internists, not to mention non-physician so-called practitioners of like physician assistants or nurse practitioners, none of them goes through this kind of rigorous training. We can tell you what you should worry about and what you can. We know when you need a biopsy and we know what to do with it. So please look out for a well-trained, board-certified dermatologist and have a total body skin exam at least once a year. And on that note, I would like to thank you for listening. This is the view from my office. I'm on Central Park South, looking over Central Park. All of you from New York and from outside of New York are invited to stop by, not only for a skin check, but also for just taking a picture of your own. And I'm now open for any questions that you have.